one, the same. Technically, it is good. The diaphragm is in. Collimation is okay. Penetration is good. It's symmetrical. No apparatus. Bones are good. The joints are okay. If I see we've got soft tissues, I can see the psoas muscles here, the shadow of the kidney, the liver, the spleen, I can see. Part of the bladder, I can see. And I don't see any abnormal calcification. I don't see. And if I follow the bowel loops, I can see part of the colon, the transverse colon, the descending colon, and they are not dilated. There is no excessive fecal material. There's no fecal impaction. So for me, this is also another normal abdominal radiograph. Okay. If you have any question, you can ask me, but if you don't, I continue. Now, this is a 44-year-old woman with crampy abdominal pain now. Crampy abdominal pain. If I follow, I do the same. Technically, though they have gone beyond, they have gone far in the chest, which is not good. Remember, collimation is not good because it's supposed to be irradiated. If X-rays, and in the pelvis, they have cut off some part of the, like the bladder, part of the hip joints. Penetration is good. It's not that bad because it is somehow under penetrated, but acceptable. And though the sacroiliac joint are not seen, that's the effect of. Can you see that by any change of inequality, any change of exposing factors, it changed the X-ray, changed the quality of X. I don't see any problems. I don't see any abnormality. Can you see? I wanted just to see everything there. There is another catheter. I don't know it is. Maybe it is the same nasogastric tube here. And again, if you go for calcification, I don't see any abnormal calcification. Very fast, I know where to look for them. For though the sacroiliac joint are not very well seen, and I have to talk about it. Otherwise, I don't see any other abnormality I can report. For S, as soft tissue, major psoas muscles are seen, the shadow of the liver. It's not an abnormality. The kidneys, shadow of the kidneys are not very well seen, maybe because of pathology here. If I follow the intestines, I can see some air fluids. By the way, remember this, when you have done, when the abdominal X-ray is done in supine position, don't expect to see air fluid levels even if there is intestinal obstruction. That's the reason why if you suspect intestinal obstruction, it's better to do an abdominal radiograph in erect position, upright position, or the patient cannot that position, that position, you can still do as you have done, or you have seen on chest radiograph, because the lateral of the cubitus will still show the same things, the same structures, but also air fluid levels, because air fluid levels will inform much about what's going on. You cannot have an intestinal obstruction without having air fluid levels, and you cannot have air fluid levels without obstruction, except in case I will tell you. So I can see some small air fluid levels. Like this is air. There is another one, air fluid level here. I can see another one there, maybe air fluid level here. And when you look, and this ball loops are dilated. They're not normal in size. Because for the normal ones you have seen, there is nothing big like what you see here. Then now my role now, my responsibility, which bowel is it, which bowel is related? Okay, because for me this is all bowel structure. Okay, can you go first of all? Is it peripherally located? For me, this is peripherally located. Upwards, it's peripherally located. Even laterally on the left, it is peripherally located. Secondly, can you see the valvular converters, or can we see the hostrations or hostry? It's not that clear, but it looks like I don't see valvular converters. I don't see those folds crossing the whole diameter. Maybe I can see part of them, but not clear. Even if I don't see them very well, it will not large bowel or small bowel. For me, as from the side, the position of colon. Look here. This cannot be small bowel here. And I think the small bowel is concentrated here as normal. That's what I think. For me, this like bowel obstruction. I remember if the large bowel is obstructed, it will go after some time, even the small bowel will be dilated. Do you understand that? It's like you have you know, it is a continuous, small bowel is continuous with the bowel. Now if you close now, the all proximal part will dilate. So now we can see this AF is part of the small this is part of the large bowel. At early stage, even this one is not that largely obstructed, largely dilated. But if you come after some hours, you will see more. Okay. For the second one, then, who can one, please? kazi I will still give example. Listen to me, iryo jambo nari rikubujije muri radiology ntabwo ribaho, doesn't exist. Wumvise neza, ntabwo bibaho ngo ntabwo bigaragara neza, ntabwo bibaho. Ushaka ibigaragara neza uzabisanga ahandi hatari muri radiology.
Ari kuzamo ibihu.
What do you mean?
Ari kuzamo ibintu bimeze nk'aho ari ibihu bigasa nk'aho biyahumye ntagaragare neza.
What do you mean? Ntabwo ifoto muri kuyireba se?
Ifoto turi kuyireba ariko harimo ibintu bimeze nk'ibihu.
I mean, ushaka ngura indi computer se?
No,
indi computer or ni kwifoto imoze imeze.
Lecture ni connection.
Connection kandi muri kubona ifoto? No way.
Yawe.
Kandi mubona ifoto?
Oya, hari igihe turi kujya tubona idasa neza ariko ubu isa neza, ubwo biri guterwa na connection y'uwo muntu.
Yeah, I mean, ntabwo ibyo bintu uvuga ntabwo ndi kubyumva neza. Ifoto deje urayibona, aramutse ari ikibazo cya connection yanyu ntabwo wabona n'ifoto, ntabwo uri kwibona. That's what I think.
Okay. Lecture, let me try.
Yeah.
Yeah, on this, let's first look about the adequacy. On adequacy, I'm looking about
just talk about abnormalities only.
Yeah.
Only something abnormal, because don't repeat everything. Just abnormal, any abnormality, inequality.
Yeah. When I'm looking on the soft tissue on large intestine.
Oh, yeah. No. Technically, do the same. You don't learn from the past, the history. Because technically, the X-ray is okay. Oh, it's not good. You can't interpret something without talking about saying something about technical quality.
Yeah, on technical, I'm looking on the rotation or symmetry. I'm looking about the correlation.
Say this. Listen to me.
Yeah.
Technically, this abdominal X-ray is okay. It has this problem. Analysis now. You go.
Okay. This image is technically okay.
Oh yeah. Technically, so ubundi ureba iki se mana yanjye? Mbese muri make usinzi bishaka kuvuga. Technically, so ureba iki?
I think it's not okay.
It's not. Uvuga ngo arimo avuga ibintu wabirebye usitabigira gute ko?
I think there is hypopenetration on the first image that makes everything.
Mwese kimwe.
Yeah, lecture.
None se ntabwo ushobora kubona nka penetration uvuze. Listen. You can see icyo tureba by definition is the spinous processes, and you can see them very well.
Yeah.
Ubwo se wavuga gute ko ari hypopenetration?
Yeah. Lecture about the correlation is not good.
Yes.
Because the diaphragm is not seen. But on rotation,
there is no rotation.
Yeah.
No rotation. The distances are okay. You don't have to measure with the ruler. The distances are okay. So,
yeah. Then let's go on the soft tissue deformities or abnormalities.
Why start by soft tissue? Because could you share with the via nose? Okay, not you require ariko uvuga the abnormalities gusa.
Yeah.
Still kubera ko tukiri kubyiga, don't just go as if you are an expert for 40 years of experience.
Yeah.
Still say B for bones, I don't see any problem with bones and calcification, maybe. C for cartilage and joint, and no problem. Say like that.
Okay. On bones.
So that I remember that you I know that you remember.
Yeah.
Go ahead, please.
Okay. On bones, there's no abnormality that I'm talking about bones.
Mm-hmm.
Also, in the joints, I'm not.
Oya, ntekereza ko sinzi imyaka yanyu uko ingana. Njye nari nzi ko young people bafite carbone nziza muri brain yabo. If you don't even niba carbone yawe utameze carbone yawe bashyira ku mapuro kugira ngo imbere bifate inyuma. Basikoresha ntabwo mufite ikaramu n'agakarine. Kwita kwa niko kubikurikiranya ntubyice. Because ndavyumva ko mu gitangira nta kibazo gihari. Ariko still nk'umuntu wiga muri university, you should kugerageza the structure, you cannot lose the structure. Ntabwo B ari bone gusa, ni bone and calcifications. None se kuki wowe utabyibuka? Niba utabyibuka wabyanditse ahantu bitwaye iki? Kina nkundi ibyo bintu byo resonance rwose.
Okay.
Wakwanditse ahantu uko structure imeze byibura ukexista kwikora neza ntuyice. Twangize isomo washaka kuzabyogerwa mu kizamini ukazabyirwa nta kibazo. Uko nzabikosora ndabizi.
Ntabwo nzabyibagirwa.
So none se n'ukuri kubyibagirwa tukiri mu isomo se?
Aya buriya kari kanjabutse.
Karabajoboka kenshi cyane.
Okay.
So please byandike ahantu basi ngahandika. For wandike A, it's about adequacy, alignment, apparatus. B, bones and calcification. C, cartilage and joint. And S, soft tissue.
Yeah. Done.
Ibyo bintu birakuranye koko. Harimo ukabikurikiranya neza. Ntabwo ari ibintu bihambaye rwose. Usa umwana muri primaire na garden yabifata mutwera.
Yeah, lecture now because.
Please try it then.
Yeah. On calcification, there is no abnormal calcification that I'm looking.
Unless you have the eyes problem, but what is this? Tell me what is this? A classification niche, by the way, classification niche. What's this?
It's a whitish structure, which is abnormal.
What do you think this is? I don't see any abnormal. What's this? Niba koko aribyo. Niba uvuga ngo nta urazi icyo. Ngaho nsubiza icyo ari cyo kuko kugira ngo ube wavuze ngo there is no abnormal classification nuko uzi icyo ari kiyingiye. What is this?
Lecture ako ndabona ari gato cyane.
Lecture rwaya amaso.
Wowe uri munini. Ari ngo nabona ari gato cyane uvuga ngo akarwara gato zakareka mu kicu sinabwiye yuko
ariko uzi impamvu kano kantu n'ubundi hari indi image twanyuzeho nyine kaba karimo
uratubwira ngo stone in the ireta. Okay, ngo karimo ngubwira gute?
Ubwo nyine nabonaga kanambwe higa bino bintu bisaba
ko ukivuga ibyo waruvuze numve ntabwo numvise neza waruvuze ngo ndababwira ngo
harako twagezeho nyine ukagira negligible.
Oya ntabwo bishoboka. Subire inyuma hanyereke.
Oya.
Aha.
Lecture. Uvuga ngo kano kantu. Ari ibyo harimo n'utundi.
Yego turimo.
Iyo museka uri guseka agashyira utuye tundi yereka nuko utabasha kunyereka kandi kari hehe. Nta kandi kubona giye. Nta kandi. Hagati hehe kandi. Hagati ukunda hagati hehe.
Lecture turi obvious. Kari obvious.
Honey bone. This is bone density. This is the wall, intestinal wall. This is the bone. The bone density. Nta handi kari ni hehe.
Ariko akana ko ushobora kugira ngo kari kuri iriya.
Unagaki ngaho mbiri cyo wakiriza unagaki. Wavuga unagaki. Either ahubwo igisigaye ni ukumenya ngo kari hehe. That's my question. Okay?
Yeah.
Icyo nzi cyo it's abnormal calcification, very tiny calcification. Ariko it's abnormal. My question is, and not mine as me, for everyone who is interpreting this abdominal X-ray, to locate is it within the is it intraliminal calcification, something someone has eaten, I don't know. Is it within the ureter? Remember the ureter passes by there. So if I'm not able to considering the clinical history, I can even go for ultrasound, even if it's difficult, for CT scan, imagine, so that I don't just miss something that is maybe the cause of the pain. considering the clinical presentation of the patient. But for this one, it is crampy abdominal pain. Crampy. This cannot cause that crampy abdominal pain. For I will start now neglecting how do you say it? Not giving it value, because if it is small, it is a stone in the ureter. Still, it is small enough to pass. It is not the cause of the clinical presentation of the patient.
Yes.
For me. Okay, so that's how we interpret, by the way. Continue. You are done with B.
Yeah, I'm done with B. Let's go on the C, cartilage and the joint. On
B
some,
normally is followed by C, A, B, C. If
yeah,
you forget.
cartilage and
And
joint.
joints.
First of all, on hip joint, I'm not. There is no abnormality there on
There
hip
is
joint.
no matter.
Yeah,
Apparently there isn't. But aho ntago matinda cyane, maybe nubwo yaba ihari ntiwayimenya kuko ntago nizere ko wabigisha, ariko sinzi ko wabigisha
yeah,
MSK, musculoskeletal and CNS, sinzi ko wabigisha, but niba mwarabyize, you should have known that there is a problem or not.
yeah. The osteoarthritis.
There is arthritis.
No, nyine rwari nk'urugero.
Mwarabyize.
Yego, muri musculoskeletal.
Mwarabyize.
Yes.
I hope kukivuga ngo ntago ubizi. So ntago nongera kubabarira ngo ntago mubizi rero, parce que mwagombye kuba mubizi, uzi kumenya niba iyi joint ari normal or not. Ko niba mutabizi nabigishe nabi, rero babigishe nabi then. Kandi mujye mvuga niba babigisha nabi tubibabaze.
No.
Forget that I told you that I'm the head of department, by the way. Niba babigisha nabi, you should tell me. Nkababaza ko mwigisha nabi abanyeshuri bacu. Mwabigishe nabi ntabyo bazi. Nanjye ibyanyu ni mwabana yoberwa bazavuga ngo nabigishe nabi kandi muramumbeshyeye. You are going to details practically. Okay? So go ahead, please. The joints are normal because the acetera is smooth and normal in density. The femoral heads are okay. The joint space is good. So these are normal hip joints, okay?
Yeah.
And if you go to pubic joint, to pubic symphysis, it's okay. I don't see any abnormality. What else?
Yeah, let's go.
The sacroiliac joints are good, as normal, smooth, no sclerosis. The joint spaces are okay. The intervertebral disc spaces are good. So nta kibazo kiri muri joints.
Yes.
Kwanza nagenda nibagiye ko mwize musculoskeletal, you should know. Na bone regions, you should know them. Otherwise, murasubiramo tu. Continue. I'm waiting for you.
Yeah, let's go on S. When you look about the soft tissues, I'm looking where the shadows of river.
Part of it, yes, difficultly.
Yeah. Also, but I'm not looking at the kidney.
Yeah, you can't see them because of any. There are some reasons behind.
Yeah. But the shadow of intestines are well seen. I'm looking centrally the smaller intestine.
How about major psoas muscles?
Yeah, also psoas muscle. I'm not looking its shadow. Where?
You can't see. Not that well. Forget about that well, but I can see this. This is a major psoas muscle on the right. This is a part of it on the left side. So, go ahead.
Yeah. Also, on intestine, I'm looking the smaller intestine and also the large one. But yeah. Okay. But there is, as I'm seeing about, there is increase in size, which will be the,
Yes, that's the
which
that's the
will
main
be,
finding, by the way. The main finding: dilated bowel loops,
yeah,
but dilated intestines.
which will be the air fluid in large intestine mainly, also, but also the small one.
Oya, umva nkubwire gatoya. Umva rero, ahandi sinzi ko mubyiga mu yandi masomo, in radiology uvuga ibintu nako ibyo uvuze ubivuga neza, ibyo utazi ugaceceka. Ni ibintu bibiri. Icyo uvuze ntabwo ukirya, ntabwo urya amagambo. Uvuga ibyo ureba kandi ukabivuga with confidence. So nturya amagambo, ntuwirukanye, tubwire ibyo uvuze ni ibiki bya air fluid levels, ntabwo ndi kubyumva.
Yeah, I'm looking the
Nonye.
which is increase in intraluminal
Oya,
size.
wivangavanga ibintu. Vuga muri niba uvuga intestines, ukavuga yuko ziri dilated somehow. Okay? So
Yes.
tangira utubwire rero bya bintu bitatu rero. Intestines tugiye kurwana no kureba ngo is it small intestines or large intestines. Ubitubwire n'impamvu. Tubwire,
Yes.
for me, I think the third one are either small or big or both. Utubwire n'impamvu ariko.
Yes. The dilated one is both small intestine and large intestine. Because
Ntabwo nakumvise byacitse.
I'm saying the dilated intestines is small intestine
Yego.
and large.
Both. Then.
Yeah.
Explain.
Yeah, I'm seeing the increase in intraluminal size.
Sorry.
Which,
byacitse.
yeah, I'm saying that I'm looking the increase in intraluminal size of both small intestine and large intestines.
Turabyemeye. Continue.
Yeah.
Convince us. Try to convince us that they are both dilated. But you don't have to show. You can talk, we know. If you say something, we will know what you are talking about.
Yeah. Wenda mbivuge mu Kinyarwanda.
Because for you to nta kibazo. Wa munyamahanga carari. Yitwa nde harya naribagiwe izina rye.
Siraki.
Siraki arahari se? Is he there?
Yes, I'm here.
Yeah, yarambwiye, you told me that you can understand some Kinyarwanda. So no problem. Use Kinyarwanda as you want.
Yeah, impamvu nari ndi kuvuga ngo aya mara matoya n'amanini byose byiyongereye. Nuko aya mara matoya ari gufata space nini cyane ku buryo turi kubona portion yayo imwe kandi tukayibona yabaye nini.
Small bowel.
Yeah.
Dilated.
Yes, as well as also large intestine.
My question is this: we are not gods to know what you are thinking about.
Yeah.
Tell us, convince us that you can see the small bowel and the large bowel. We know to see how to mentor us, and that is the main role now. You should understand very well. Tubwira ukuntu wabonye ko ari dilate, ko ari large bowel and small bowel. How? Ureke kutubwira ngo wabibonye nta kazi kawe n'uburenganzira bwawe. Ntabwo turi abanyamategeko mu rukiko. But tell us how.
Yeah. How?
Kandi twazize mu gitondo twize how to differentiate them.
Yeah, wenda nuko ntapimye.
Gupima byo twemeranyije yuko they are dilated for sure. You can't miss that dilatation. They are dilated. I can see dilated bowels. Icyo twacyemeye. Ntabwo tubijya impaka ahubwo izihe, which ones?
Yeah.
Uko size nta nubwo size cyane dufasha, sorry, understand. Nta nubwo size cyane dufasha for differentiating the small and the large. Ntabwo dufasha cyane burya size, the caliber, the diameter. Ikidufasha ni location Location of those dilated bowel loops, and
okay, lecture. Small bowel is
valvular conniventes or saucily.
for small intestine, and Hauster for large intestine. The small intestine is centrally placed, while the large is peripheral.
That's anatomy. Oh, you're talking about this.
Lecture, menya nawe ntari kumva ikibazo neza.
No, turashaka utubwire ibyo uvuga yuko both are dilated, utubwire uti icyo ndi kubona, ndabona small bowel hano ziri dilated, ndabona valvular conniventes wenda simbizi, ndabona ziri centrally located, and peripheral nkabona large bowel nazo ziri dilated, ngo ndabonamo ibi n'ibi. That's what I want to hear. None se ubwo utabivuga se turamye kuvuga ibiki? Icyambere umwana nabeshya kamaze ngo guca intege kwanza, ibyo uvuga ntago ari ukuri. Niyo mpamvu uvuga ngo ubuse turamenya uri kuvuga ibiki koko.
Lecture, ibyo ndi kuvuga n'ubundi uko nguko ubivuze nanjye niko nayo mbivuze. Mvuze ko small bowel iri centrally located, ikaba
tabasha kubona iki kibazo cya online teaching. Online teaching ni kibazo you cannot show when you are not presenting, sibyo? Hari yakunda hari gishaka guhereza umuntu uburenganzira bwo kwerekana.
Maybe
I don't know.
Akomenya bitakunda hari.
Ntabwo byakunda utari gupresent ariko look here. Look then follow mutaza kugira confusion. I don't want you to have confusion here. What by just looking, I said start by the bigger picture, though I wanted you to go always by systematically. But I can see the standard bowel, like this one is standard, this one are the standard bowels, this one are the standard bowel. Even this one, can you see? Those are the bowel that are the standard. But from there, this distended bowel I can see here. They are first of all centrally located, then the center. They are filling almost the whole abdomen because they are distended. And again, something very important that can convince me that is small or large, they have valvular conniventes within them. Can you see that these folds, very smooth folds, thin, they are crossing the whole diameter everywhere, even here. Can you see? Even this one, it is crossing the whole diameter. It looks like it is peripherally located here, but it is because of they are distended. And I'm very sure these are small bowel. It's dilated small bowel because of those two things, location and valvular conniventes. And now, if I want to be 100% confident, I will go and look for the large bowel now. Where is it? And immediately I can find one. Look here. There is large bowel here. The area of light iliac fossa is area for cecum. And you go up, the ascending colon, I can see it here peripherally. The transverse one, I can't see it because it's covered by, superimposed with the dilated small bowel. But here I can see the splenic flexure here of the colon. I can see it. I can see posterior to this small one, I can see air in the colon. But this time I can't see it is collapsed somehow. Maybe in the rectum, I can see some air in the rectum. So from this, I can confidently say this is a small bowel obstruction. The dilated one, small bowel loops, and the colon is collapsed. The large bowel is collapsed peripherally. So this is the case of small intestinal obstruction. Okay? Biragenda biza buhoro buhoro. Kuko icyo ntakwemeranyije cyawe watubwiraga nyine cannot ntitwagomba kumenya niba wowe kwanza bavuga ngo zose biri dilated nkibaza yazibonye hehe. We yabonye hehe large bowel distension? Ntabyo ndi kubona. Okay? Can I continue? Maybe let us continue and we'll see many more courses and we'll end up by understanding what I'm talking about. So this is the first case you have seen. We talked now these are like explanation. I can even go ahead and jump this because you have seen this image you are seeing here is the same as the first one here. So the idea of giving explanation saying that we can see air fluid levels, multiple air fluid levels, and in a small bowel obstruction, they say it can be either small bowel obstruction or large bowel obstruction. If we see this now, or it can even be a dynamic ileus. Sinzi niba muyizingi dynamic ileus, umuntu wamubaze mu nda, umuntu afite bamuteye imiti, kinya, ugasanga amara yose they are not functioning. There is no peristalsis. They are not functioning. That's a dynamic ileus. Nayo ishobora gutera air fluid levels. Ahangaha barimo baribaza baracyari kuri fazi kuba they are asking themselves what can it be. Even air fluid levels can be caused by gastroenteritis. We try to kureba the cases. So these are possible causes of air fluid levels in plain abdominal X-ray. When we say that's the information I want to give here, the causes, okay, of air fluid levels. Now let us go into details. Obstruction of any peristaltic tube, proximal dilatation, and distal collapse normally. When there is obstruction of any peristaltic tube, proximally it will be dilated, but distal it will be distal to the obstruction it will be collapsed. Ibyo ni ibintu byumvikana, it's logical. Okay? When it is about small bowel obstruction, remember small is proximal and large is distal. So the small bowel obstruction, dilated, it will be dilated small bowel to the level of the obstruction, and now distally there will be collapse of distal small bowel and colon. Birumvikana. Mu gihe hazaba hari small bowel obstruction, the part that will be dilated will be at the level of the obstruction. That will be small bowel obstruction, dilatation, and distally the part of the small bowel remaining, small bowel will be collapsed. Even the colon, the large colon, the large bowel will be collapsed. Birumvikana. In case of chronic obstruction, large bowel obstruction now, there will be dilatation of small bowel and colon to the level of obstruction. And now it will be associated with collapse of distal colon. Now the small bowel is no longer there in the collapse because the entire small bowel will be proximal and it will be dilated. Okay? In case of generalized adynamic ileus, nababwiye impamvu uzasanga kenshi both small bowel and colon and even the bizaba dilated ko adynamic ileus akenshi usanga ari generalized. So the entire GIT will be not functioning, it will be dilated. And in the case of, but also you can have what you call generalized adynamic ileus or focal adynamic ileus. Focal, it can happen in the case of focal inflammatory disease, in the case of maybe appendicitis, pancreatitis. We know that because of infection, because of inflammation, the bowel loops that are adjacent, that are near the focus of infection or inflammation, they will not function. They will stop functioning. Only the bowel loops that are near the inflammatory focus, in appendicitis, in the pancreatitis, or any other inflammatory process in the peritoneal cavity, the bowel loops that are nearby, they not function. They will stop functioning because of maybe the inflammation and pain, and then it will be focal adynamic ileus. And in this case, it can mimic small bowel obstruction or chronic obstruction, because if it is near the colon, they will not work, they will not function in that part of the colon. Even proximally, the rest will be dilated because it's like obstruction, though it is not obstruction. It's not functioning. If it stops functioning, the proximal part will be dilated. So tell me, do you understand this slide? Because the rest of the slides you are going to see will be based on this understanding. If you have any question on this slide, ask me. If you understand very well, we continue.
Lecturer, I still have a misunderstanding about a dynamic.
Your network, please. Your network's not good. We didn't hear you.
Yes. Right now you can't hear me.
I can hear you very well.
Okay. Yeah, I still have a misunderstanding about your dynamic areas.
A dynamic areas, it is non-functioning bowel loops, young intestines, due to any either general cause, not obstruction, not due to obstruction. There is no obstruction, but the bowel loops and the intestines are not functioning. Kumuntu wabaze munda, akenshi usanga niko akondo ntuzi ko ntabwo murabimenya this. Ntuzi ko wabaze umuntu munda bamubwira ngo bamuza mu ibyo kunywa cyangwa kurya nyuma y'amasaha 28 cyangwa 48. Uzi impamvu?
Ntabwo nyizi baranamubwira ngo azabanza asure.
Aha, voilà. Ibyo bivuze iki? Bivuze ko amarayi ntago ari muri icyo gihe ntago akora. Ahagarika gukora. Amarayi ntago ari gukora muri icyo gihe kugeza yazongera agakora. Iyo niyo bita adynamic ileus due to surgery, abdominal surgery. Cyangwa se umuntu wateye ikinya, general anesthesia, nawe amarayi arakira gukora for some time. Cyangwa se ikindi cya gatatu, iyo ni generalized. Ariko iri focal nayo ishobora kubitera iyo hari inflammation mu nda, appendicitis, pancreatitis, amara bowel loops zegereye aho ngaho hari inflammation, nazo zihagarara gukora, nayo bayita focal adynamic ileus. There is no obstruction, but there is no functioning of the intestines. Nabyo bikuri on plain abdominal X-ray, it looks like there is obstruction somewhere, though there isn't. Urabyumvise noneho se?
Yes, for sure.
Good. So iyi slide murayumva neza ko mu gihe hari obstruction kuri large bowel, colon, proximally even the small bowel will be involved. Igihe hari obstruction kuri small bowel, this study there will be collapse of the rest. Birumvikana.
Question, lecturer.
Yes.
On the previous slide, you have told us that on this second image, we have both small bowel and colon dilatation after small bowel obstruction. But according to this explanation you have given us about small bowel obstruction.
Oya.
Irahari. Icyaha cyo kubeshyera umuntu se kibaho kiremewe.
Cyanditswe mu
lecture kuri second image bari batubwiye yuko hose habayeho dilatation.
Uretse gatoya. Ibyo bintu abandi musubize. Ibyo bintu uri kuvuga ariko navuze.
Oya. Ibyo ni Fabrice wabivuze.
Akwembekera.
Ibyo ni Fabrice wari uri kubitubeshya.
Ariko nyine namuhinyije yambwiye ko atari byo.
Yego mwavuze ko large bowel yabaye collapsed.
It collapsed ahubwo peripherally, it's collapsed. Small bowels are dilated, small bowels are dilated, ariko the large one is collapsed. None se ko bihinduye none ndabigira gute? Urafata ibya Fabrice cyangwa urafata ibyanjye?
Ibya Fabrice.
Oya turafata ibya lecture.
So none se ubwo ni mu cyungo. Ngaho ikibazo cyawe nakishe rero. Yarambeshye kandi ribu yagufunga de.
Yamufunga da.
Kuko ni icyaha cyanirwa n'amategeko. Kuba ari umunyarwanda, kuba afite imyaka iri hagati ya 10. Kwese twagiye?
Twagiye.
So he's trying to kumvikana umukobwa simvise byaje kubaza nayujije ariko yambekiraga niyo mpamvu nabyanze akurikire Fabrice
naze
naze kabisa fata ukuboko. So let us continue then. So if this slide now is very well understood, we can continue. The rest will be very easy. So let us, maybe you need to already consider now bowel gas pattern. You have to identify which loops are dilated and which are collapsed. That's very important. Small bowel, normally they are thin, they are regular, circumferential folds, what we call plicus circularis, valvular conventers, within the central abdomen, the location. For the colon, they are thicker, normally the thicker wall, irregular folds. So irregular folds, hostrations, special location. Vertically oriented, the colon is vertically oriented, ascending colon and descending colon. U-shaped transverse colon, and the rectum, the center of the pelvis, and sigmoid colon can mimic small bowel because they are, you remember, if you follow the descending colon, it goes like this: splenic flexure, descending colon, sigmoid goes into the center. It's like this. That's used to say the sigmoid colon can mimic small bowel loops and vice versa. Okay? Aka kantu nako mwari musanzwe mukazi, you course twabivuze kenshi, we talked about this, but please remember this. It can help you to differentiate the both. So this is just a gross anatomy of what I'm talking about, the plicus circularis for the small bowel. They are these ones at the mucosa, the villi, Kamieko, submucosa here, muscular layer, circular muscles. This is just gross anatomy, just tell you what I'm talking about. When I say plicus circularis, you have to understand what it is. So still, listen to me. Still, this is the image I told you we have seen. Sibyo? And here the image, they want to tell you that the causes of small bowel obstruction, the most common one is adhesions. Adhesions, that's represented by 6%. Adhesions, someone who has been, they have operated in the abdomen or has had abdominal scar gatuma ifatanya mara kaba yagira obstruction caused by a surgery or caused by inflammation or an infection in the history. That scars now can cause, that's what we call adhesions, and can represent 6% of the causes of small bowel obstruction. Hernia can also cause the intestinal obstruction, small bowel obstruction. Neoplasms, 15% also. Either the neoplasm on the primary small bowel or the expansion of a mass to another small bowel is maybe mesenteric tumor, but extending to a small bowel. Peritoneal spread, if it is in a peritoneum now, it can even cause obstruction to GIT, or hematogenous spread from any other cancer, other area, chest, or any other area, not abdomen, but can spread through the blood and can cause obstruction to the GIT. So, you know, these three adhesions, hernia and neoplasm, they are representing 90% of the causes of small bowel obstruction. Okay? And the rest now, we can have some more, like an inflammatory bowel disease, EBD, IBD, inflammatory bowel disease, like Crohn's disease, mara yumvise, insusception nayo ishobora gutera, nabyanditse nabi, ntabwo ari insusception, midgut volvulus, abdominal abscess, inflammation can cause either focal dynamic layers, even the abscess compressing of the small bowel and cause obstruction. Radiotherapy, XRT, radiotherapy and radiotherapy understand what is going on about till the skull, like the lesions, radiotherapy, parasites like scaly twigeze kubona umwana mu Rwanda, umwana ufite za scaly nyinshi cyane mu mara zigafunga zigatera obstruction, intestinal obstruction, cyane muri Afurika barya imyanda n'iki. Endometriosis nayo can cause intestinal, endometriosis can in the pelvis, in the peritoneum, igatera obstruction, and gallstone loss, sibyo. So those are many causes. When you see a small bowel obstruction, it is not enough to say that it's a small bowel obstruction and just do a report. If you are able to see on imaging the cause, it will be better. Because if I don't see the cause and I report a small bowel obstruction, the main important role or big work will remain for the surgeons or the clinician who is following the patient. Because even if I say it's small bowel obstruction, the doctor, another doctor now, the clinician, the treating doctor will go far and find the cause. Because by finding the cause, he will be able to treat the patient. Okay? Birumvikana neza? So this is another case. Let us go. Another case of a 41-year-old woman with Crohn's disease. It was known that Crohn's disease is inflammatory disease of the intestines. And when you see, let us follow the same system, you see this first abdominal X-ray. It was not good because the cut of the diaphragm, but this is okay. I don't see apparatus, I don't see B bones, I don't see any problem. Calcifications, I don't see any abnormal calcification very fast because I know where to look for them. And C joints, sacroiliac joints are very beautiful, demonstrated. Symphysis pubis is good. Hip joints are normal. The joints from the spine are good. So S now, soft tissue, very well trained major psoas muscles. The outline of kidneys on the left and right and left, part of the liver, spleen, I don't see it. Intestines, I don't see any dilatation of the intestine dilated because I can see fecal and air within, abdominal air and some fecal material, but that's not exaggerated. This is normal, by the way. It looks like normal, but if you sell some not more, maybe it's the first time we see, but for this second one you see better. Yeah, but here I can see some air bubbles that are not looking like normal. But here now don't say it is normal because I can see like small air fluid levels, and it looks like there are small intestines, air fluid levels here. There are these ones, this one, but also there are some air bubbles here. These are not normal. That I was looking here. They are not really normal. This is in the radiology you have, when there is no dilatation of the, even if they are like fluid levels, but the intestine self-dilated. So iyi sign rero ifite izina ryayo muri radiology, you can know it mwayibona, remember it. It's called string of pill sign. String of pill sign. Look, I have magnified the image. Look how they look. They appear here. String of pills sign. You see, this is a sign. There are air bubbles in the small bowel. This is a sign. It's the air collecting under and below. Remember, plica circularis. Remember, plica circularis in. So that air is collecting under this, and if they are collecting under this, and this sign is seen as of Crohn's disease. Crohn's inflammatory disease, Crohn's disease. Okay. last time you see this, ibibazo birebire ahubwo bifata menye of pill sign like this one, think of disease. Symptoms the patient will be having persistent and chronic abdominal pains. Yeah. Okay. Clear. String of pill signs. The air collection under and view plica circularis.
Your cursor is not moving.
Oya narangije kwerekana ibyo narekeye n'ibyo nashaka kwerekana ntabwo muyibona.
Nawe iri kugenda.
Ariko na mbere nabirangije uzajya ngo nyiho nkore ngira gutya.
Yari library lecture, yari library.
Oya ariko nabiberetse ko ndababwira
Sign rwose twayibonye.
no hejuru irahari.
is a air collection. No hejuru hari. These are string of pill signs. It is air collection under plica circularis. Kandi plica circularis mwayimenye ari. Okay?
Yego.
So, iyi rero ni sign ya Crohn's disease. Twagiye. Barimo baravuga nyine ko nayo ni small bowel obstruction due to Crohn's disease. Small bowel obstruction kubera iki? Even if it is like this, it's like there are some air fluid levels. Even if it is not that dilated, cannot obstruction. The sign you have seen the sign air fluid levels, so there is somehow obstruction, though it is not complete obstruction, but sting of pain. So twagiye rero. This is that has been she was by is presenting in. Let's start by this one. Who can try? Can you try? The diaphragm is bad. It's bad, but in the case, the patient has abdominal distension and pain, and you cut off the diaphragm. Maybe it is pneumoperitoneal. How can you? I know makosa kome but the pelvis is okay. Technically, the rest is all good. Penetration is fine. There is no rotation. Maybe there is one small, but not much. So, for bones, problem. Some maybe it's in the gallbladder. Why not? Can you see a classification here? Yeah, well, maybe
bigaragara neza lecture.
Nawe ntabwo ijambo rijya rivugwa. Reba inshuro zingahe koko. Never saying ntabwo bigaragara. Yes, niyo mpamvu to see that very well seen.
Richard
One.
lecture niya kora
Yes.
Like up.
no
Hey.
zabuka gakeya. No,
hano ni noza.
Awegereye
Onga.
Oya ahanga nta gihari.
Hari lecture turi kukibona.
Oya, listen to me. Follow this rib. This is the cortex of the rib.
Cortex.
Yeah, the cortex of the rib. Rib is a bone. That's the cortex of the that's an abnormal classification.
Ahangaho biragaragara ko iri hagati ya ribs rwose.
This is the cortex of the rib.
Ariko na hariya no bitandukanye.
Follow the rib. You will see this is the cortex of the rib. Another one is up there with the cortex. Between them, there's
Lecture,
Mm.
lecture, the question was
Mm.
nuko kesi zose twabona ni gute twabona cortex bwa mbere aka kanya codified gutya.
n'ahandi mwabibona dusubiye inyuma se ntabwo muri kubibona se ubu se hano ngo utavuze ko hari classification ko utavuze ko hano hari classification look
ntayihari
aho nta bihari ntabwo
Aho
bigaragara
reba
biri
hano ko
prominent
utavuze ko hano hari
biriya.
classification mwabaye mute utavuze ko
please
ari isasi
Fuck.
classification is this this the part of the rib. Can you see this rib? The 12th one.
Bizaza.
Bizaza ariko akangaka ni abwana bwari kamwe ahubwo mwari muzi kutunga utari tubiri. Two classifications. Can you see? Hello?
No lecture turi kubona
There are two.
Yes.
Ambara rinete za wasize. Wasize there is one, this one, there is a touch ni iruhande rwabo. So I think this they may be in the gallbladder, gallstones. Why not? But what the next step will be, I will do ultrasound to see where they are. Ultrasound. But twigendere now. Twari turi kuri one is the classification. Hanyuma tugiye kuri C. Join the join impamvu yo ko that was in this not a case. Really, I can see it on left one. I don't see very well outline. Symphysis is good. Ha, twagiye kuri intestines there. Ninde wayigira icyo tubwira kuri intestines?
Distended.
Which one then? I can see distended bowel lobes, but which one?
Small.
I think they are the large as they are peripherally located.
Ibyo rero ntabwo ari ukuvuga ngo large or small, mumva ko bamwe bavuze large abandi small, but dukoreshe noneho science tumaze kumenya. We know how to differentiate them.
They are both.
Before
both
you
direct
think
distended.
twice.
Both are distended. Means that the large bowel obstruction.
Dusobanurire more. Tell us more. How are they both distended? First of all, can you see air fluid levels? Yes? Air fluid levels? Suizas, if they go, can you fluid levels on this X-ray? This one, the left.
Yes, lecture.
C'est vrai. Hehe ubwo
njye ntayo ndi kubona
nta nimwe mbona nimwe nanjye
nayo mbona
dufite amaso atandukanye harimo amaso ya hamasi n'aya ntoza
The one we see blackish in the large ball.
Yes, ubwo se nta air fluid level mbona ntayo mbona nta urabona oya nta air fluid level mbona je ariko kuri iyi foto second image fluid level air see them many
Yes, lecture twari twibeshye
mwari mwibeshye. So my question is, why don't you see them while there is dilatation of the bowel? Why don't you air fluid level? Who can answer the
This
question?
is I think that this image is taken while the patient is in a supine position.
Which position?
Supine.
Exactly. This image was in this, but they have taken it position. They are the patient. nabyumvise
twabyumvaga
medicine yanyu iri hasi cyane
tuzajya mu wa gatanu ariko byaraje
mushobora kutazagerayo muzagerayo mutawutsinze radiology
Kahise bigorana.
nidutambuka
nyine hari umunyeshuri wigeze kujya kwipa radiology kera ntabwo nzi ko muzayitambuka mutari gusubiza se how
lecture nidutambuka rino
icyo kibazo
somo
gikomeye
kazaba
rero
kabaye
aha niho hari umunyeshuri wakwepaga radiology kera ntangiriye nigishaka physical nazaga Huye nkajyaga ko ako gako yari itaratangira kwanza I was in Huye that was like and nkamagabiri mu ishuri rimwe 200 more than for me nararaga cyane nkavuga nkasarara noneho bagakwepa amasomo yanjye nkango gutya this sinshaka kurikira ngo ndareba this nagasigara umwe uri bunsubize ko hari gusa see so exam no nyitanze ko my exams are they are not ntagari nta text uzabona nkubaza hano cyane for like maybe one question, two questions text to ariko ubundi ni practical my exams and you will see
utaduha practical kandi arizo dukeneye
dutanga no muri practical kubera yuko tuba ntabwo tubabwira ngo ntabwo tubaha impapuro tura project
ibyo ntabwo ari sawa
ntabwo
ikibazo gifite umunota umwe iminota ibiri according to the so umunyeshuri rero umwe makumyabiri
urumva nk'abantu dutinda kubona vuba abnormality tutazaba tugowe
uzi ko wagira ngo Imana uri Adamu cyangwa Eva uri Adamu se niwe Imana itangiriyeho kurema niwe muntu wa mbere wize radiyo
ese
umugabo
ntabwo umuntu wakurikiye arabikora utakurikiye ntabwo wabishobora uretse izi details wazibwirwa nani
reka tuzabitsinda ntabwo tuzagutenguha humura
sawa nayo ndahari so izindi causes of chronic obstruction the same inflammatory bowel diseases, coronary diseases, ulcerative colitis that is involving in most of the cases can involve the whole colon but mostly involve the descending colon and the caliber becomes very small, it's narrowing and the colon loses the folds usangari very smooth wall ikaba narrowed bigatuma proximally iba obstructed how the dilatation interception the same okubayanditse nabi volvulus muraza kuireba radiotherapy can cause because of the scar parasites same endometriosis the same urebye the causes of small and large obstruction urabona ko zishaka kusanga hari kimwe the same it will be depend on the location of the problem so 56 year old man now with lumbar radiculopathy lumbar from the lumbar radiculopathy under treatment they have done laminectomy mwabyumvise buriya clinical history ihita ikubwira what will be who nahise numva what's going on they have done laminectomy now with abdominal distension okay so who can talk about this the first image ntihagire ugerageza ndeba amazina yanyu mbabwire se kwa kundi banza nanibagiwe n'amazina yanyu kanyarebe noneho mwese mwagiye irambona arayandi ariko garagara sha Niyonzima Jean kari he Niyonzima Jacques ari he arahari se Niyonzima Jacques mugire vuba vuba iminota yanyu itancika ntabwo nongera gusubira aya masomo sinakujya gusubira mbere yanyu ngo ndabigisha simbishaka
Yes. Yes, yeah.
Niyonzima just comment on the first image on the left according uko twabivugaga try to comment on it.
Okay, thank you. Technically, it is not well-centered, as I cannot see.
Okay, understand. I agree with you.
The penetration is good.
Technically, it's good. It's not good. Okay. Hanyuma ariko still we can interpret. Go ahead for the interpretation.
Yeah, okay. The next one on bones, I can see there's no problem with bones, but there's something I'm seeing whitish, which I'm thinking it's calcification.
Hey, where? Baby. You forget to talk about this apparatus, this tube-like structure here.
Okay.
That is in A. Adequacy, alignment, and apparatus. Yeah, but no problem. What was the classification here? I don't see it, sincerely. I don't see one.
Down there on the iliac joint.
Hey, hano se. Hano ntabwo ari muri film. Ahandi ni hehe. Uruzi ko nangira ubuze kuvuga ko mfite classification kuri jewe kandi hanze. Where is? Nta classification ndi kubona je.
I was wrong.
Abnormal classification. What else? Ahubwo ikibazo cyawe gikomeye. Ntukabeshye ngo bones are normal. Urabona spine ari normal ko reba even harimo scoliosis, harimo osteophytes. Scoliosis, urabona si iri alignment ntabwo imeze neza, iri scoliosed. Look.
Yes.
Urambeshya ngo ni normal. Ntukajye mubeshya. Hari na osteophytes ku ruhande. Osteophytes has spondylotic changes. Now disc spaces is narrowed, like look here.
Yes.
So ntubeshye rero sacroiliac joint are normal, very well seen, outlined, bones are okay. Ariko ntubeshye ngo spine imeze neza ngo bones are normal. Kino kinyoma.
I didn't look on the spine.
Ntabwo wigeze ureba kuri spine.
Yeah, that was the problem.
Oya kandi ari bone, na part of the bone. Sinambwiye ko you should not ignore any.
Bizaza teacher.
Okay,
then on C, the joint on here, femoral joint is good. There is no problem with it.
Yeah, twavuze ko joints are okay. Nabikuvugiye,
Yeah.
Apart from the spine where there is narrowing of disc spaces.
Then on soft tissue, I can see there is small bone dilatation.
Ozil, when you're interpreting, it's like you are going to say chest radiograph kuvuga ngo there is consolidation. Consolidation in terms, it's not a descriptive term, it is a diagnostic term. Because there is consolidation in left lower any diagnostic term. Now rero kuvuga ngo there is dilatation of large small bowel. Nayo it's somehow wagiye kuri fine, wagiye kuri conclusion. How to get it is there is bowel lobe dilatation, marked dilated, ukaba tuvuga ngo they are peripherally or centrally located. I can see valvular converters or hostile. I think this is this. You know, you are describing from your description tugahita tumenya utaranangiza kuvuga tumenya ngo you are talking about large or small bowel. Okay?
Okay.
Turafamo?
I can.
Subira rero ibyo ubona rero.
Ticha ko bitari kugaragara neza si bise bihinduka biri kugenda bihinduka.
It's not me, it's you. It's your network, ntago ari jewe.
Maybe ndi kubona biza byongera bihita bigenda.
So let me ask from the audience. Any who have seen something?
There is distension of the bowel that is centrally located. It has vascular. It has the polyvented. Yeah. Okay. Yes. So I think as they are centrally located.
Can you see them? Valvular converters, where are they?
On this on the second image.
Oya turi mu ya mbere ariko wogiye muri zose se twego turi ya kabiri naho turayijyamo.
Okay, I can see them.
Where?
I have no cursor, but
Oya
I think I can see.
Where? Erega radiology ntago ari gukoresha cursor, ntago ari ngombwa cyane. You can call it a name tukamenya aho uri kuvuga. Kabusho kuvuga uti left lower quadrant, left upper quadrant, you know. Centrally, I don't know. Tukamenya aho uri kuvuga. Vuga si byo yavuga twumva. Sinkubwiye ko bivuga.
In the upper left quadrant and the middle lower quadrant.
Okay. Reka mbyimvuge kugira minota yanjye itancika gusa ndamwe ko saa 10 zigiye kugera. Hasigaye isaha imwe sinshaka ko twose turara tutabirangije ibintu. Generally, there is dilatation of bowel lobes. Icyo gihe ikintu cya mbere gikomeye. If I go into details to know if this small or large, I will try to go into details. Location, they are everywhere. Peripherally, centrally, they are just filling the whole abdomen. And the remaining part, the remaining finding to look at is about valvular converters or hostile. If I take like this one, I can see they are not crossing the hole. Like I can see this is not crossing, this one is not crossing. Maybe you can say this is crossing, but it may be even not. If I go here, I don't see the hostile or valvular converters. If I check this one, maybe they are crossing the whole diameter. They are crossing the whole diameter. If I got this one, they are crossing now. This I'm very sure these are valvular converters here. So I can conclude this is now large bowel obstruction. Kubera yuko both large and small bowel, they are dilated. So this is large bowel obstruction. It's the same patient, I think. Yes, still the same. Can you see the osteophyte? Mwambwiye ko mwize ibingi bagonje kwa bari babwiye. Nababwiye ko they should give you the common, show you the common diseases. Kuburyo mwana nawe muzamenya nka spondylosis. Spondylosis ni ibintu muzahura nabyo every day. Lower lumbar pain, low back pain. Muzahura na lumbar spondylosis cyane. Izire kuba iberetse. Umva these osteophytes laterally with the sclerotic end plates. You see, this is osteophytes here. But the same case, You can see this is crossing the whole diameter, meaning this is a small bowel. But if you go to others, you don't see, you see the pustule, or you don't see any. So this is now large bowel obstruction because it's involving both the small and large bowel. Okay?
Yes.
Aha. Let us talk about the importance of the cubitus radiograph. Normally, for the patient who cannot stand up, they can use the cubitus radiograph to visualize, for you to see if there are some air fluid levels or not. Okay, for you to see air fluid levels, remember you have to be in erect position, the cubitus, or yeah, most of the cases those are two. Here we don't see the air fluid levels because the patient was in a supine position. It's the same case as what you have seen before. This is the same as this. Okay, and air fluid levels can still help. So this was the case of adynamic ileus, because both the large and small intestines, they are dilated. Maybe it's not the only cause, of dilatation of both, but in this case it was a dynamic ileus. You remember I told you that can be generalized, where all intestines are dilated, or focal, where caused by inflammatory diseases like pancreatitis, appendicitis, peritonitis. But in case of peritonitis, in most of the cases, it is generalized. So in generalized, can be following abdominal or thoracic surgery, I told you, medication like narcotics, anticholinergics, or anesthesia, metabolic disturbance, hypokalemia, hypocalcemia, hypomagnesia, hypothyroidism, cirrhosis. All of these could be cause of adynamic ileus. This is a case of adynamic ileus. There is no obstruction, but the intestines are not functioning and they become dilated. Okay, so nuzera ko byumvikana neza. And if you see this kind of X-ray, you have examined the patient, you can yourself diagnose. You can also think of adynamic ileus, but I want you to remember it. It is one of the common causes of dilated bowel loops. Another case of 35-year-old Jamaican. Mwumva ko identification ari ikintu gikomeye. Jamaican man with history of eternal abuse, now with abdominal pain, diarrhea, 10 times weight loss, yaranutse cyane, malaise and weakness. When you check the left image here, technically not good, very good, but not bad, because of they have cut off the diaphragm, but the rest is okay. I can see this apparatus. I don't know which is a catheter, I don't know. The bones are okay. Calcification, this is not a calcification. Remember, this is not a calcification. It's just apparatus. And the apparatus, part of the apparatus. I don't see any abnormal calcification. The joints are okay. The soft tissues now, I can see dilated bowel loops here. Peripheral located dilated bowel loops here. They are dilated, man. It's not normal, even on the left side laterally. But by checking, it's peripheral located. But this loop, bowel loop, it has valvular conniventes. That's what I can say. On this one, I am convinced that these are even thick, hostly. This is very thick to be part of the small bowel. I know even the location, this is colon, slightly dilated colon here. But when I reach here, this is small bowel because it has valvular conniventes crossing the whole diameter. Can see them, appreciate them. Even this one can be part of the small bowel. If you see on this another one, there's some air bubbles, not air fluid, small air fluid, air bubbles in small bowel. The small bowel because they are centrally located. Small bowel. Peripherally, I don't see anything much. But this small bowel, air bubbles, air bubbles, air bubbles. Sibyo. Iyi nayo nk'uko twabonye string of pills sign muri Crohn disease. This is another sign we commonly see, especially for children. Sibyo? Gastroenteritis. You onye air bubbles in small bowel. Air bubbles. Remember, there is no gas or air in the small bowel, but you can see air bubbles in small bowel like this one. Think of gastroenteritis. And it is the first cause of air fluid levels. You can see, yeah, but they're talking about the small air fluid levels. Air bubbles, but making air fluid levels. The bowel loops are not much dilated, especially the small bowel here. They are not much dilated. If you compare this, even if you see this small bowel, they are not dilated. Maybe here on the first one is colon some, but small bowel, even this one, it's not that dilated as such. Those small air fluid children. Umwana adia abdominal pain for 3 days. And when you do abdominal exercise, you see these small air bubbles and small intestines. Okay? Ntabwo nongeye kuba ijambo cyangwa gusubiranyije kurabirangiza.
Yes.
The on the left side, patient was no abnormal classification, but I can see this apparatus. Can see when you're operation with the heart, I don't know, in here. But the bigger picture, it's dilated. Okay. The bowel loops, which bowel? I can see first thick. The folds are not closing the whole diameter on this one. But when I come to this one, see? Small and the large bowel are direct. And they say this is a case of 54-year-old woman. Let's say it. Okay. Okay. Now, machine. this pathology? Hello, neck. They told you about neck?
No.
Little bit.
No.
Is it the first time to hear
Not the first time,
necrotizing
but
enterocolitis?
Yes, it's my first time.
So I heard it a bit.
It
not the
is
first.
it's a condition for especially for premature neonates when they have infection, and now there is a collection of air within the wall of the intestines due to infection in the intestines gut. But also pneumoperitoneum can be caused by ischemia of the gut. Remember, twabibonye na mbere, in case of ischemia, there will be presence of air in the wall of the intestines, or in other conditions that can cause infection of the gut and cause now perforation of the gut and the pneumoperitoneum. We'll see the case of neck. Neck, we'll see the case. So there is what you call legal sign. Legal sign, it's a sign. Legal sign, it's a sign that is very useful in plain abdominal X-rays. As we have seen silhouette sign, have you seen air bronchogram and chest X-ray? Legal sign can help you. Sometimes you do a plain abdominal X-ray in spine position. Okay, in spine position. Remember, in spine position, you cannot see much, like a collection of air, free air under the diaphragm may not be able to see. But in this case, this legal sign can help you to know that there is free air in the peritoneal cavity or not. What is this now? It's when normally we are not able, on plain radiograph, we're not able to see the wall of the intestines, both near the lumen and out of the lumen. Because air is intraluminal, we see the wall, but the only part near the lumen of the intestine or the bowel lobe. But when you are able now to see both sides of the wall, like as if there is air out, air in, that's what you call legal sign. It's a sign of pneumoperitoneum on the supine radiograph, air on both sides of bowel wall makes wall appear as a thin white line, like the way you see it here. It looks like there's air intraluminally and air out, and this is a legal sign. And this is a sign of pneumoperitoneum, presence of free air in the peritoneal cavity. It's called legal sign. turayumvise inkomeze undayirangire nta kindi muzayikoresha kenshi.
Yeah.
Ari neza.
Ntabwo nahembese neza.
Ushaka
ntabwo byumvikana.
Ushaka murenze y'iki? No sindarenza y'iki ko nandi magambo mfite kuvuga se.
White line is not visible.
A white line is not visible. It is. You see, let me show you other images. Within the images, you can't. By the way, this is the case of pneumoperitoneum also. Ariko handi, for example, like this. Can you see that? You can see the wall of the bowel wall,
yes,
but you can't see that line. Now, whatever on both sides, out and in, whatever the wall you can't see. Hatari perforation even here, you can see the wall. Another side, there is no presence of air. You are on the side lumen. Okay?
yes.
Umva hano nta legal sign ihari. Ni mvuga ngo nta pneumoperitoneum ihari. Ariko tugiye hariya you can urabona yose ari near the lumen and even out you can see.
Okay.
Okay.
Yes.
Mwabyumvise noneho se?
Birimo biraza.
Bizaza buhoro buhoro mushaje. So another sign is about football sign. Nayo ni sign nkuko twavuze izindi zose, but this is sign that is very useful in plain abdominal X-ray. What does it mean? The same football sign, it has the same role as regular sign because it tells you that there is presence of free air in the peritoneal cavity. And in this case, this is magnified or collimated abdominal X-ray, where you can see this is the river for information. This is right upper quadrant. This is the river. And the river now has a shape of American football. By the way, it's American football sign. It's called football sign, but it's American football. American ball. Football. Niko bayimera. Numuzi ko ariko bayita. Ira bakina ya rugby ni balo.
Yes.
Aha. It has the same shape. Impamvu yagaragaye rero, you can see the contour of the river because there is presence of free air in the peritoneal cavity. Up there is air, down there is air. It is also another sign of pneumoperitoneum. Wabyumvise se? It is also It is also a sign of pneumoperitoneum on spine radiograph. The combination of the liver shadow and air outlining the falciform ligament is there. It gives the appearance of football. That is American football. Iyi nayo ni kimwe na regular sign ariko they are showing different things but for the same purpose. Mwabyumvise nabyo? Do you understand this sign? Both zigufasha in case of supine plain abdominal X-rays. Ko mutamusubiza ngo menye ko nkomeza cyangwa ndekera.
Twabyumvisha.
Okay, umuntu umwe arahagije. So summary, simbirangije sigira ngo. Summary ntabwo niba nyisubiramo kwanza. Ngiye kuyihora kuko nabivuze kenshi the same. Near identification, ABCS, and in summary, ibi ntabwo niba mbisubiramo. Murabizi, muzabyisomera. So, akanababwira gusa nakangaka. This is not for this only, even for chest radiograph. My method may not suit all, so it is best if you adapt it. Kuko something koresha or find or create one that works for you. Ikingenzi nuko uba systematic kandi you look all. See everything in the image and you see it systematically. And good luck then. So, reka turebe cases vuba twihuta rero. A 30-year-old man with 6 months history of epigastric pain. Epigastric pain. Wibuke ya surface anatomy of the abdomen. Epigastric pain. Occurring 2 to 3 hours after meals. And anorexia. Presented to accident and emergency with sudden severe epigastric pain radiating to the back. Abdomen exam revealed rebound tenderness, guarding, and rigidity. What are the diagnosis? From there, radiology comes after having a list of differential diagnosis normally for a good doctor. But you should examine take history and combine those two and have a list of differential diagnosis before you go for any lab or imaging tests. How could this condition be managed? That's the question. Now, ushatse narekera ahangaha ariko ukambwira ngo what do you think? Ngaho mumbwira differentials here.
Lecturer.
By the way,
Pancreatitis.
this is a very good pancreatitis. Nyuma ye 6 months history of pelvic pain. Ariko se kubera iki byaje nyuma y'amasaha 2 cyangwa 3 ariye? Ega mugongo kubyibaza.
The lecture.
No, I'm not teaching
It
you
may be
radiology.
gastric ulcer.
Yeah.
It may be a gastric ulcer.
Yeah, kubera iki hari rebound tenderness and guarding.
There is inflammation, lecture.
The inflammation of pancreas.
Nabasharengize abaganga babigisha clinical examination baje babigisha case nk'izi ngizi ziba challenging. Urambwira ikintu kimwe nkacyemera ariko nkakubaza kuki harimo rebound tenderness and guarding and rigidity.
Teacher, the inflammation.
Inflammation from where? Is it peritonitis?
Pancreatitis.
It's a biliary tree. There is inflammation of the biliary tree. Maybe gallstones.
Gallstone gatera
Abdominal
Gallstones actually they cause the right upper quadrant pain.
Yeah, that's localized pain.
Lecture.
Even epigastric can be. Sorry for that. Sometimes patients come with epigastric pain while there it is gallstone. It happens. Okay.
Lecture.
You should combine both.
Pancreatitis, doctor. Acute.
Pancreatitis.
Yes, lecture. Because the pain radiates to the back.
Inhibitor guarding and rigidity of abdomen. Ese kuki mudategereza kuri perforation?
Radiating to his back.
Kuki mudategereje kuri perforation? Gut perforation. Baby, because of
it can be in differentials.
By the way, it is the one. Ntabwo navyuka ko ari ariko it is the one. When they have done chest radiography, found fear. Ntabwo nibuka ko ari ariko it looks like it is pneumoperitoneum.
Yes, teacher, it's a complication of pancreatitis.
Megatems that are guarding the rigidity of the abdomen. Oh yeah, the most likely cause is peptic ulcer perforation. Because remember, bavuze ko amezi atandatu baba epigastric pain for 6 months. Nyuma yamaze kurya agira that signs zindi. So most likely it's about stomach and peptic ulcers. But perforation. Challenge now. Ntabwo nsoma biriya ntabwo ushaka kubisoma kugira ngo twihute. Number 2. A 70 mujye mukurikira. A 70-year-old man. Muzo kuvuga ngo no ovarian torsion. Presented with periumbilical discomfort localized in which surface anatomy and abdominal bloating after meals. And fever, very important sign, fever. Hey, kwanza bavuga peritonitis ntabwo bavuga pancreatitis na fever bigeze. Okay. Upper GI endoscopy was found to be normal. Muza kumbwira ibya peptic ulcer. A barium meal and follow through. Murabyibuka? Study nayo babwiye muri general overview was carried out. What are the differential diagnoses? How could this condition be treated?
Appendicitis.
Appendicitis?
Yes.
Bakora barium na barium. Periumbilical discomfort and abdominal bloating after meals and fever. Either way, fever. Mm-hmm. Diverticulitis akenshi it concerns the descending colon on at the flanks, left iliac fossa. In most of the cases, by the way, descending colon. Hano bavuza periumbilical discomfort. Gatekereje kuri za Crohn disease n'ibindi cyangwa. By the way, hey, ndabona bavuzemo ko this is Balium Pro true. That's how it looks like. And by the way, they said that the large verticular. Small about the verticular. It is not common. Sorry. It is very rare, sincerely. My thinking. When the supporting element here, it's that bloating, every time bloating after a meal. Periumbilical bloating, but small bowel diverticular, they are very rare. And diverticular are these ones.
Question.
Yes?
In the question, they say that the GI endoscopy seemed to be normal. Is it possible to
endoscopy
have...
uzanigera endoscopy rega nagirenga kuri uretse kugera he igera kuri
ligament of traits.
Ntago barenga hari.
Yes. Ligament of traits.
Yeah. Kandi ligament traits muribuka hayiwa ihuza iki niki?
Upper and lower GI.
Upper and lower, which lower and which upper? Say it specifically. Come on, muvuge ubyo nabyo nje kubigisha koko anatomy isanzwe. Ligament traits itanfatanye n'iki?
Lecturer kuri duodenum and the duodenum and the what? And the diaphragm.
The what?
Diaphragm.
And the diaphragm. Google it. Let me continue. Okay. Is that the case? Okay. Maze rero kamabwire abo nigishaka mu ishuri nababwiraga impanuro nyinshi kuruta ibyo nabigishaga ngira ngo nibwo ntabwo ngira umwanya wo kubibabwira. Listen to me. If you want to be a good doctor, sit down and read and repeat and read again. Don't enjoy Champions League. Don't enjoy the conversation in the evening only. Take your time and not listen. Medicine is too wide.
And don't sleep.
Kandi mbabwira ikindi kimwe, don't think ngo nubona diplome ngo bizakugira akamaro. There are many doctors who are not muzabireba umwanya wataye uri ku ishuri, the time you have spent at school on the books igira repercussion in your life. Sibyo ntuzasanga umuganga umwe afite akora akazi ahantu hari afite ahantu hatatakora wowe nta namwe ko they know you that you can't help in anything. Ndibuka twiga muri medicine umuganga umwe turi mu wanyuma muri doc 4 in the last year. I was rotating in CHK at emergency. The fourth year yari umwana w'umukobwa rwose w'ikizungerezi hariya babandi batafata umwanya wabo rwose bafite uzabibakora. You see kwa kundi bato behavior noneho listen twakoraga rotation hamwe bigeraho tubona umurwayi tugomba guhereza afite abarwayi bari kureba nanjye mfite abanjye agomba kumuha paracetamol ndakubwiza ukuri ahageze ananirwa doze yayo iramunanira arimo akawanyuma aza kumbaza ngo harya paracetamol batanga kangahe. I cannot forget this. Ariko twadusanze tuzi ko ari umuntu nyine she doesn't have much in her head. Ushaka kumubona yicaye ari gusoma, ushaka kumubona yivunnye she's not a medical doctor, really. She's someone who has done medicine by her own means. I don't know. So if you don't sit and read books and read again and try to discover new things, yego uzabona diploma ariko ntabwo uzaba uri umuganga ndakuzi. So nk'ubu rero mbabaje ngo ligament of Treves n'uwabivuze ntiyamenye ibyo ari byo, ihuza iki n'iki, ifatiye mukabananira, ishuri ryose rikananirwa, akabona n'umuntu n'umwe, even one student ubisubiza. That's a very bad sign. Let us go. The third case is a 16-year-old boy presented with a short history of left iliac fossa pain. Short. Aya magambo afite akamaro. Short history of left iliac fossa pain and bloody diarrhea. Streaked with mucus. Kandi kose kaba gafite akamaro. Aya magambo abarwayi bakubwira ngo ugiye ngo bimeze gutya na gutya, aba afite ikintu. Stool cultures were found to be negative, normal. Flexible sigmoidoscopy showed an acute colitis. Acute colitis, not chronic. Despite being given IV steroids, he developed abdominal distension and became systemically unwell. Systemically, not systematically. Systemically unwell, the whole body. What are differential diagnosis? How could this condition be managed? What do you think? Habaye case nziza cyane. These are very good cases. Nuko dafite umwanya ngo tuzitindeho ntegereze kwerekana the answers. But they are very good cases for both radiology and both medical side.
I think I can say ulcerative colitis.
Sorry?
I can say ulcerative colitis.
Ntabwo ndi kumva neza.
I can suggest ulcerative colitis.
Ulcerative colitis. Maybe is it something acute sense koko bavuze yuko babonye colitis. Yeah, why not? Yeah, it's possible. Diarrhea, yeah, why not? It's possible. Ariko nuko ubwo bavuze colitis ni mpamvu bitekereje cyane ngira ngo. Aha, this plain abdominal X-ray was taken, shows a dilated colon. This is the colon, dilated colon, with evidence of mucosal edema. Mucosal edema, no, listen to me. Mucosal edema, it is, urabona ziriya za ibyo bita hostile. They are very thick. Thumb sign. They are very thick. Thumbprint sign. Wagira ngo bashyizeho igifu abandi babita thumbprint sign. Utera igikumu. Ugiye kureba ukuntu bimeze wagira ngo bagiteye hano na he. Thumbprint sign ni sign ya edema. Mucosal edema. Even these hostiles, they are very thick. Very dilated. Ascending colon. Ariko the last one, the descending one is somehow reduced in, it's not dilated, but still you can see the hostile, they are very thick. So the appearance are those of toxic dilatation. Toxic megacolon. Have you ever heard about toxic megacolon? Toxic megacolon. Have you ever heard about it?
No.
Write down your notebook and go today and read about it, because this is not just radiology, it's in general medicine. Read about toxic megacolon, and you remember that you have seen the image in favor, and the radiological evidence of colonic dilatation. Yeah, it's dilated. And any of the three following: fever. Hey, they said that he has fever. I don't even remember. They said fever. They said the patient had fever. I don't know. Fever, tachycardia, and leukocytosis. When you work with the laboratory. So Let me reka numve uyu muntu nanone tena. Hello. Yes. Mwabirangije se? Inde? Wowe ukora the last, wowe ukora ntuza yawe ya nyuma, urebe ibitameze neza, urebe ibintu byose, ibitameze neza ubyandike, rero byo kuzakora ibisigaye bazakora kugira ngo uvugane nawe kwa. Yenge ndacyari kwigisha ariko mukandarangiza mitenza. Nta kibazo. Cyangwa se muzane nawe duhure mu nzira nta kibazo. Ariko wako banze barangiza nandi ndabandangiza kwigisha nta kibazo. Nta kibazo. Okay. Iki muravuga iki? Ko mungorerana. So toxic megacolon. Okay? Can you go to next one? Hello? Can you go to next one?
Yes, please.
Yes.
This is a 89-year-old woman presented with 4-day history of absolute constipation, absolute constipation, and abdominal distension. Examination revealed a grossly distended, non-tender and tympanic abdomen. Sigmoidoscopy showed an empty rectum, and at 25 centimeters, a large amount of fecal fluid and gas was accounted with relief of her symptoms. What is the differential diagnosis? How could this condition be managed? Any idea?
Lecturer is the large bowel obstruction.
Obstruction.
Yes.
Obstruction is bakabonamo matili ikaba ari yabiteye se. Why do you think of large bowel obstruction? Large bowel obstruction kubera ko afite grossly distended abdomen, not non-tender. Tender abdomen obstruction iri tender, ariko hano bavuze ko ari non-tender and tympanic abdomen. So have you ever heard about sigmoid valvulus? Sigmoid valvulus, coffee bean sign. It's like a coffee bean. Can you see this image? It's like here. Sigmoid valvulus normally kambaye ako valvulus muziki aricyo. Namara the bowel loop yizingazinze kuri yo. Sibyo?
Yes.
Part of the bowel loop, especially the colon, yizingazinze. Dufite ubwoko bubiri bwa valvulus. Hariho sigmoid and cecal valvulus. Sigmoid rero akenshi the involved bowel loop iragenda ikagwa on the right side of the abdomen, ariko cecal valvulus igwa on the left side. Ibyo ni ikintu cyagufasha kubitandukanya. The cecum imaze kugira valvulus, it lies on the left and sigmoid lies on the right side, though anatomically those two, it is the opposite. Cecal on the right side normally it will go on the side, on the left side, opposite side, and sigmoid to go on the right side. This one now, it looks like it's lying more on the right side than left side. This was the case of sigmoid valvulus, coffee bean sign. Okay? We're not calling it dilated colon. I'm very sure it's colon because you can see the hostulations, hostly. They're not crossing the whole diameter and they're dilated. And this, it has a shape like coffee bean sign. That's very important to see. When you see this immediately, immediately see it has a shape of coffee, and you think of either valvulus or sickle valvulus, sigmoid or sickle. Now, according to the location. Okay, komeze. Another case is flail 85.
Let's continue.
Okay. Flail 85-year-old woman presented with a 6-month history of rectal bleeding, rapid weight loss, rapid means something, and change in bowel habit, in particular, increasing constipation. Hepatomegaly and ascites were apparent on abdominal examination. A barium enema, not barium meal, enema revealed this finding. The finding we are looking for. What are the differential diagnoses? How could this condition be managed? 6-month history, rectal bleeding, rapid weight loss, change in bowel habit.
I think it's a mass.
Think of a mass is okay, bowel habit, maybe obstruction, I don't know, because of kuzama hepatomegaly and ascites, I don't know. Is then, yeah, maybe, ariko wavuze ko bariya enema ariyo yerekanye the condition. If bariya enema ariyo yerekanye, it's no longer a mass. Okay, maybe ushaka kuvuga ko ari chronic mass. Ahubwo hari umuntu waravuze iyi condition, hari umuntu warayivuze mbere. Hari wayivuze, though it was not true, but for this case it is. What else? Ugerageze twumve. Try it. All conditions. Colonic,
Hepatitis.
Oh yeah, hepatitis bayireba kuri bariya enema. Bite byawe?
Hemorrhoids,
hemorrhoids, aho bidahuye ni rectal bleeding nta kibazo, weight loss no. Hemorrhoids bayatera weight loss.
Chronic cancer.
Wow, ahubwo ni chronic cancer is, Ninde waravuze tumor? Ninde waravuze tumor? Waravuze tumor.
Ulcerative colitis
nayo irashoboka kuyikora gutya, ishobora kuboneka, ariko this case was about, have you ever heard about apocore stricture, apocore sign? This is a barium enema, normal one here. When you reach here, it looks like muribuka nayo babwiye apocore sign. Apocore sign ni igihe wagira ngo ni epo yariwe, ubona yariwe hagati agasigara hejuru no hasi. Murabibona ukuntu bimeze? Sinzi ko nashyizeho ikimenyetso, ntabwo nzi nashyizeho ikimenyetso. Apocore sign. Urabona hano?
Wagira na agapome.
Olo?
Wagira ngo ni agapome yariye.
Nagira agapome yariye noneho agasigaza the upper part, akarya hagati. Ni ukuvuga ngo yariye hano harasigara this, urabona?
Yes.
This is a very important sign of chronic cancer or GIT cancer. Yaba esophagus, iboneka ahantu hose, muri esophagus, muri small bowel, muri large bowel. Iyi apocore sign, it is a sign of cancer.
Yes.
Okay. Hanyuma summary now. Ubwo singiye kubirangiza. Summary of a systemic approach turayizi. Identification, ABCS, iyi summary turayizi. Ahubwo kambaho izindi case vuba kugira ngo iminota 30 ya nyuma nashaka dusubira kuri chest radiograph images tukabirangiza saa 11 turaba turangije nta kibazo. This is a CT scan, abdominal CT scan axial. That is part of the pelvis. That is showing dilated small bowel. That's That's small bowel dilatation. Okay? Small bowel dilatation. So when you see this on CT scan, the rest will go and see where is the obstruction. But this is small bowel obstruction. Fluid-filled small bowel. You know the thin wall, multiple small bowels. The colon is here. It's no longer even difficult because on CT scan, it is easier to differentiate small bowel and large because like this is a collapsed large bowel here, but the rest is small bowel dilatation, fluid filled. So it's this small bowel obstruction. Now we look for the sign. Now you look for the area, at the region of obstruction. Yeah, this is small bowel obstruction. And now there is what you call this. This, can you see even this one is small because the colon is here. You can differentiate the colon with air, but fluid-filled bowel loops. These are dilated small bowels on CT scan. But there is something I want to tell you. It is about this sign. One bowel. Please switch off your mic, please. Can you please? Who's the mic on? I could. Even if the small bowel dilatation, one of the small bowel loop, it has a faces. These are fecal material and it should not be seen here. Sibyo ntabwo wagombye kwibona na gato. This is called feces sign, small bowel feces sign, and it's an indication of where the obstruction is. So when you see a picture on CT scan of small bowel obstruction, and you go and search for this small bowel feces sign, when you can see it, you know exactly that around there, it's where the obstruction is. Small bowel feces sign. Okay? This is the area of transition. This one you know very well. If I give this an exam, you will immediately say, who can tell me what it is? What's this? Diagnosis here, please be faster.
Pneumoperitoneum.
Yes, pneumoperitoneum. There is free air under the right diaphragm. Pneumoperitoneum. Sometimes on chest radiograph or abdominal X-ray, that free air can be difficult to see. Like in this case, you can be a very small, mild collection of air here. But sincerely speaking, if there is no this arrow, you can't tell me. But on CT scan, you cannot miss. On CT scan, that small one, it can become easy, it can become evident. Sorry, evident. This, I wanted to just tell you that if you have the signs of pneumoperitoneum or gut perforation, and you do chest X-ray and you see it's somehow normal, don't lose your courage. Go ahead and investigate by using CT scan without contrast, plain CT, and immediately you will see that there was perforation somewhere. Okay, that was the message here. So that is whole of vascular perforation. Initial chest radiograph demonstrated tiny volume of fluid. Oh, you can even miss. But you can be seen on coronal CT image, evidently. So this is the ultrasound of the liver in color and the gray ultrasound of the liver. This is the liver, this is the diaphragm, remember? The diaphragm in the liver. There are some two hypoechoic regions in the liver. What do you think this can be? Who can answer? What can they be? Liver
abscess.
Yeah, liver abscess. These are liver abscess. Can be a cyst, but looks like a thick coat, somehow irregular, and the content is somehow turbid, like this one. The content is turbid. Here, not very well seen because of the color they have put. Ultrasound can change the color, by the way. Don't think it's another machine. No, you can change the color of, but we like this one. We like this gray, white gray color. So we can see some turbid fluid content. These are abscesses. Yeah, it was liver abscesses. Okay. This is, who can tell me this examination is what do you think this is? Examination procedure. Which one?
Angiography.
Eh?
Angiography.
No. Which are these? What is this? What do you think this is? This. What do you think this is? These are biliary system, biliary tree. This is common bile duct in the duodenum. Second part of the duodenum, the pancreatic duct will pass by there. This is common bile duct, hepatic duct, intrahepatic duct. This is bowel. This is gallbladder. This examination is called MRCP. Cholangiopancreatography. MR. Cholangiopancreatography. MRCP. Turabikora muri MRI. Ikintu cyo twabonamo gusa nuko ari dilatation of CBD. Common bile duct is dilated, but you can see a very feeling defect, hypointense. Ntabwo tuvuga dense, cyangwa echoic, tuvuga hypointense feeling defect distally in the distal part of the CBD, common bile duct, but also another one, the gallbladder. It's a very good procedure to examine in the biliary tree. So this is now choledocholitis, stone in the CBD, choledocholitis, but also choledocholitis. Stone in the gallbladder is choledocholitis, but stone in the CBD is called choledocholitis. Okay, with proximal dilatation. This is called MRCP. Yes, called the diagnosis choledocholitis and choledocholitis. Okay, sava. Don't have cases kugira ngo mubimenye tu simple kugira ngo ntimuzajye mwumva ibyo bintu mwumve ari ibintu bihambaye. So this is, who can tell me the diagnosis here? I choose the name. Let me choose the name. Here mugomba kubimenya iyi ngiyi. Ndashaka umuntu witwa Ndera Ange Aimable Israel. Ange Aimable Israel. Ila ya nyuma ni Hamas.
I'm here, teacher.
Ya nyuma ni Hamas, ni L cyangwa ni H? Kuko harimo Israel.
It's Robert.
Hamas.
Let's call it Hamas. Tell me, what do you think this is?
I think
Robert, amazina menshi. Ange. By the way, aramunyeshuri nigishije witwa Ange w'umuhungu. Ushaka ko ari umwana wa mbere cyangwa wa nyuma?
Wa kabiri.
Kuki bakwize Ange?
Ntabwo mbizi.
Inyuma hari abandi, imbere hari undi. Oya, abana muvukana. I mean,
turi batatu.
Wowe uri hagati.
Marayika.
Nyine impamvu bamukunze cyane bakamwita Ange no kubera iki? There is a reason.
Yeah, I don't know.
Wa mbere ni umukobwa n'umuhungu?
Ni umukobwa.
Wa nyuma?
Umukobwa.
Niyo mpamvu ubwo ni baragukunze bagatikana bahungu kamwe rwose ni kamarayika kabisa. So tell me what you see there.
So lecturer, he told us that the sigmoid
vulva. Exactly. This is Coffin sign. Kandi murabibona neza cyane.
Yes.
Kandi it is now lying on the right side, coming exactly from the sigmoid area. This is sigmoid volvulus. Okay, very well. Look how it looks like. This is descending colon. No kizinga. That's how it looks. That's how it happens. Sigmoid volvulus, Coffin sign. Okay, is it clear now? Okay. Can I go? So
Yes.
sigmoid virus. Now, who can take this is abdominal CT scan, axial plane. What we can see, this is a bowel loop, even these are bowel loops, but in which this bowel loop is dilated somehow, and within it there is another structure looking like a bowel loop. Actually, it is what after operation, that's what you have found. We are seeing this at this level. There is a bowel loop within another one. That's what we call, tell me the term, interception. Okay? And the names can change according to which part of the bowel is involved. It can be colonic, it can be ileocecal, it can be ileo, even okay? So this is interception, okay? Who can tell me this is abdominal ultrasound using a linear probe, not abdominal probe, curvilinear, it's linear probe, but you can see a structure looking like a bowel loop, and within it there is another structure looking like a bowel loop. Look, bowel loop, there is even fluid collection within it, within this collection, a bowel loop within another one on ultrasound. It's a target sign. Look at the target sign. This is also another how we see interception on ultrasound. Target sign is it's this one, a link with another link, target sign on ultrasound. Okay? Who can tell me what you see here? This is my menyere cyane. This is plain abdominal X-ray. Technically, A is good. If apparatus there, B bones are okay. C joint are good. S now. Who can tell me? Can you see that they are dilated bowel loops? They are dilated, like this one is dilated, and this is a colon because there is a hostrations. They are covering the part of the bowel, lumen, caliber. But there's some another dilated colon, but it's like a fecal material here. So can tell me? Sometimes, listen, sometimes in case of constipation, you have constipation, there is fecal impaction, the distal colon, and proximally, the proximal gut is dilated. But it is not a typical obstruction. It is pseudo-musical lack of, it is pseudo-obstruction. It is obstructed, but not completely, to call it intestinal obstruction, but there is dilatation of proximal part because of fecal impaction. So this is now, we call it pseudo-obstructive constipation. On a fecal material, but proximally, the colon is dilated. It's not intestinal obstruction. Something is passing, but it has a picture of intestinal obstruction. It's now called pseudo-obstruction, large bowel pseudo-obstruction due to constipation. Okay? This is the linear probe ultrasound of the abdomen or pelvis, where we see this structure. It comes out very clearly. Thick walled structure with peripheral, that is hypoechoic, with a center that is hypoechoic. And when you measure it, it has they didn't show the number, but it's more than 6, like 7 diameter. There is a reason why they have measured it. So this is now appendicitis. This is appendix that is thickened and dilated with fluid content within it. That is appendix. This is appendicitis, how it looks on ultrasound. In axial cut, if you do another view, another longitudinal, you will see it very long. Like, I don't know the reason why I forgot to mention it here, to put the image here. I will put for next time for you. By the way, before I give this. This is acute appendicitis. When this diameter is more than 6 millimeters, that is a dilated appendix. On CT scan, it is very easy to diagnose appendicitis. You cannot really miss it. If you miss it on ultrasound because of maybe air in the gut, in the GIT, you can miss it on ultrasound. Remember, air is the enemy of ultrasound. You can do CT scan. The CT scan you cannot miss. CT scan, air is a good window. Here, on CT scan with contrast, bien sûr. Contrast, now it's not plain. Contrast, first of all, you see that round like bowl loop like structure, small structure with air within it and thick enhancing wall that is surrounded by what you call stranding, fat stranding. Fat stranding is inflammation of the fat, mesenteric fat. Look, this fat here, it doesn't look like here. Here it is clear, dark, but here it is like some whitish fat, meaning it's inflamed fat. It is called in English, in radiology, you call it stranding, fat stranding. It's a sign of, it's another sign of inflammation. But the appendix is this one, this is dilated with wall thickening and enhancing. Normally, in normal circumstances, the appendix doesn't show this thickened wall and enhancing wall. No, you can't see it that way. Even other, like the wall of the colon, you know, it is not thick, it is not even enhancing. How come the appendix is enhancing and the wall thickened the wall? Okay, this is a case of acute appendicitis. Okay. Another case is this one. If you see very well, this is also linear. They use linear probe ultrasound of the abdomen at the level of epigastrium. And if you can see, there is something like this. There is something like this. It's like a keyhole. There is a dark muscle-like dark structure on each side. And within it, there is something content like lumen. Huh? I know it is strange. What I was showing, I know you don't get it immediately, but with time, when you come to rotating radiology, you will see this many of these. Normally, this is the muscle. That's the pylorus, by the way. This is the pylorus, the whole of it, that is elongated with muscle that is thickened, pyloric muscle on one side and pyloric muscle on another side, and the lumen now is here. The whitish is the lumen with content. Maybe they have given some contrast. That's the reason. That's a content of the in the lumen, by the way. So otherwise, it is elongated and thickened. Both muscles are thickened. This is hypertrophic pyloric stenosis. When you do a barium meal, it becomes even easier to see. It's like it is called keyhole sign. This is pylorus here. This is the stomach. As it's coming out to go to the duodenum, it has this sign. This is keyhole sign. It's a sign of hypertrophic pyloric stenosis. The pylorus is elongated and thickened. The muscles are thickened. Abana baza baruka. They vomit, projectile vomit. Okay. So demo is this a common example so that mubimenya, yeah, hypertrophic pyloric stenosis. Aha, here we have abdominal X-ray of a baby neonate where you have a distended stomach. This is a distended stomach with absence of gas or air distally. It looks like it has maybe duodenal stenosis or something else, because this is what you call gastric outlet obstruction. There is nothing passing. There is no air passing from there. So in this study, there is absence of gas or air. Most likely it has duodenal stenosis or duodenal atresia or something. Gastric outlet obstruction, yeah. We don't know. It might be even this hypertrophic pyloric stenosis can cause these kind of things. By the way, that's cause of pyloric muscle spasm, hypertrophy. Or when you do X-ray, plain X-ray, you see that it's distended stomach because nothing is passing, and distally there is nothing here. This is another abdominal. We call it when you check for the neonate, for the children, when you take both the chest and abdomen at the same time, we call it babygram. That's the time to use. The exam is called babygram. Like an X-ray of chest and abdomen at the same time. What we see this is the stomach, the center stomach, gaseous dissection of the stomach, but also we have another pouch of gas. This sign is called double bubble sign. Double bubble sign. It can be seen on ultrasound, even on X-ray. Double bubble sign. It is also another sign of duodenal atresia or stenosis, because in most of the cases this time there is no gas, there is no air, nothing is passing, but there are bubble. Before it was one bubble for the stomach. That's the reason why it was gastric outlet obstruction in case of pyloric stenosis. But if there is another bubble, this is for the duodenum now. This is the second one is in the duodenum. So meaning it is duodenal stenosis or duodenal atresia. Okay? You see the stomach and then duodenal atresia. This is the case of duodenal atresia if you see this. You can do now barium meal or barium follow through and see where there is obstruction. Yeah. The double bubble sign may be duodenal atresia. Double bubble sign. Who can tell me? Nagira umuntu umubwira dore numve ko mwabimenye basi. Who can tell me about this? Now this is a normal case nk'izo twabonye kare. Who can be courageous and tell me? Technically, don't talk about it. They are okay. Very big person, obese person, they have done plain abdominal X-ray in supine position. What are you seeing? Go straight to the S.
Bowel loop distension.
Bowel distension. It's the main finding, but which bowel now is concerned?
Small bowel.
How do you know? Yes, these are dilated bowel loops. They are centrally located and they have valvular conniventes, very, very well demonstrated. And the colon is peripherally somehow collapsed. This is the colon on the right, on the peripherally. This is part of the colon peripherally, and even the rectum here. It looks like the descending colon is collapsed. So this is small bowel obstruction. When you come in there, I will give you some examples together in a group. Small bowel obstruction. Who can tell me? But this one's the first time you see. First of all, apparatus. You can see nasogastric the tube. You can see it. This is the stomach. You can see some dilated bowel loops, but this is diffuse bowel loops dilatation. Diffuse for a neonate. It is a young. This is a neonate. Can see from there, you have the identification, very important. And what you see, apart from the dilatation of the bowel, slightly dilated bowel loops, you can see that there is air in the wall. Can you see? Can you see?
Nemi corona.